Well, tell us about what happened, because I was concerned
Yes.
at the end when
I know.
that you didn't remember the name of your Drexler.
Oh no! Did I give the impression that I didn't remember his name? No, I remembered his name.
Oh, okay.
But he had taken off. He took off as soon as I fell. He had gone after that coyote. So let me know where you want me to start, and then I'll definitely.
Well, let's start right in the same way you gave it at Toastmasters. That was a very nice delivery.
Absolutely. So about 5 weeks ago, as I was out and about taking my dog for a walk, as I usually do, we were walking down a sidewalk close to the Mormon temple at just a very gentle pace, and everything was very calm. And I've noticed that we were going slightly uphill when a coyote passed across our path, and my dog just went ballistic. My dog's name is Drexler, and he had this supernatural strength that I had never experienced before. In spite of the fact that he had a harness for a collar and a very strong leash, I was not able to restrain him. And he started to run in the direction that was opposite to where we had been walking. In other words, he started to run downhill. And because it was downhill, he started to drag me, and I started to run alongside him as if I was willingly running with him. And so that encouraged him even more to run faster. Then he cut across a parking lot, and the parking lot surface, the blacktop was broken in certain places, uneven in others, and I knew I was going to fall. The reason I was holding on to him and not wanting to let go is because a few years earlier, we had lost our dog, a Chihuahua, to coyotes. And I subconsciously felt like if I let go of him, that the coyote, which had by now disappeared somewhere, was just trying to bait him and lure him into a trap. Well, I fell with a big thump, and I knew I had hit my head because I clearly felt my head bounce off of the blacktop. But I tried not to think about the pain so much, although I was immediately cognizant of the fact that I had sustained a head injury. I got up and started running in the direction that Drexler had gone. Drexler was probably 100 yards away from me at this point. I could see him, but I did not have the strength or the agility to run after him. He kept running, I kept yelling after him, and he kept moving in the direction where he thought the coyote had gone. So an angel in disguise was coming from the opposite direction, a man who took the risk of slowing Drexler down and grabbing his leash and bringing him back to me. So by now, I was really, really exhausted. And I knew that I had to get to the hospital. And that's because the thought of a family hit me at that point, that their young son had fallen at the event of a bachelor's party. He had fallen in the bathroom and hit his head a few years ago. And I kept thinking of him, and I kept praying. I said, God, I don't want to end up like him. Well, long story short, he had not gone to the emergency room right away. And 3 days later, he started to experience some of the telltale symptoms of a concussion, which later turned out to be a brain bleed. He started experiencing visual problems. He started experiencing nausea. He started to experience an excruciating headache. So 3 days after his event, he went to the emergency room They put him in a bed, and he never woke up. I mean, never got up out of that bed, and he's still bedridden many, many years later.
Mm.
So that was the, the scenario that kept replaying in my head. Like, I don't want to end up like that. I have too many responsibilities. I kept praying. And so I started to do these mental gymnastics in my head, trying to count backwards from 100, just to see if I was, mentally sharp. And I noticed that I was able to do that without too much interruption. I was not having any headache at the time, but I walked back home and I asked my wife to drive me to the emergency room. We went there, and I went and took a seat, and it was a hurry up and wait game, because I was at the emergency room for 7 hours without any medical attention. And when I had gone to nursing school, we had been trained that 2 injuries, a head injury and a heart attack, need to be triaged, and they took priority over everything else. So I didn't know what was going on, because 7 hours after not being treated, I noticed it was 5 a.m. and I just basically decided to come home. And the next day, I called my doctor at Kaiser and told them that I had not been seen at the emergency room, but I needed to be seen. I wanted to rule out any type of a brain bleed. So they asked me to come in to the urgent care at Kaiser. I went there. They did a CT scan on me and gave me a clean bill of health, saying I did not have any fractures and I did not have any bleeding in my brain. So that gave me a shot in the arm. I felt like I had gotten a new lease on life. And I came home, rejoicing in the fact that I was okay, and I was going to be okay. So that's my story. All I wanted to ask you, Dr. Young, is what are some of the symptoms of, or what should a person expect after a fall like that, or a head injury like that? Could you tell me a little bit about what a concussion is versus a traumatic brain injury?
That's a very good question, because it's something that people need to know in order to determine their prognosis, and of course for doctors to decide what kind of treatment they need. The first thing to do is make sure that there is no TBI, or traumatic brain injury. This would be not necessarily as obvious as one might think. In the past, we would assume traumatic brain injury had to be accompanied by a skull fracture, blood in the brain, either a subarachnoid or a subdural hemorrhage, or an epidural, which is blood outside the brain, but it compresses the brain in such a way that it can cause brain injury. And then, of course, the contusion itself, which is the brain bouncing inside the skull and producing bruises, just as if you were to bruise your hand or hit your thumb with a hammer on the surface of the brain inside the skull. Those are subarachnoid hemorrhages, the small ones, but they are actually the worst because they are typically missed, and those patients do end up frequently with epilepsy. And we would call it mild traumatic brain injury because there is no obvious bleed in need of surgery the day it happens. A subdural, for example, would be an obvious need for a surgery evacuation, but it would be only moderate traumatic brain injury because a subdural is placed in the between layers of the brain lining and the skull, so that the brain is almost protected from a direct injury or contusion to the brain tissue itself. A subarachnoid affects brain tissue and causes a scar that leads to epilepsy, and it's inside the thick skin membrane of the brain and of course inside the skull. A subdural is between the thick membrane and the skull. And so it's a little bit, the brain is farther away and it doesn't suffer from the bruising and of the bleed and the hemorrhage deposits that later cause scar tissue and epilepsy.
Okay.
And they, those patients then, whether they have mild or moderate TBI, then need to be treated. In addition to prevention of seizures or future epilepsy, they also need to have cognitive rehabilitation, because frequently with mild and moderate and of course severe traumatic brain injury, but even the mild form will have symptoms of memory loss, lapses of awareness, blurred vision, hearing fogginess, and sometimes tinnitus, which means ringing in the ears, and of course headaches. And these symptoms are often not from the brain. A headache, for example, is not because the brain hurts, but because the tissues around the brain are irritating nerves in the membranes outside of the brain. And everything, including the sinuses and the skull and the dura mater, those have nerves that cause pain. But the brain itself could be very, very damaged and still not have pain that you perceive.
Is that, Dr. Young, because the brain itself does not have any nerve endings or nerve cells?
Well, it has all the nerve endings in the whole body, ultimately, okay, but it doesn't have them from itself. So in other words, it's almost like the brain can't see itself in its own mirror.
I see.
Which is an interesting concept of self-awareness, but it's true. The right parietal lobe has representation of every part of the body, including the skull and the scalp, but not of the brain itself.
So, I guess my next follow-up question would be, does the brain have pain receptors?
Well, right, it doesn't have pain receptors. Pain receptors are in the linings outside of the brain, the dura mater and the skull. Anybody who's ever hit your head to the point of going through the skin and actually hitting the skull, it is extremely painful to have any bone break. Bones have a lot of pain nerves, and a broken bone, whether it's the skull or your arm or your leg, has a lot of pain because the body wants you to know that something serious has happened, a broken bone.
It's a protective mechanism, in other words, that makes you aware
of the pain.
Of the pain, yeah. As far as what to do in a situation like this after you have had a head injury, what are some things that a person could watch out for, Dr. Young?
The first thing is that you want to make sure that there's nothing serious. So of course, brain imaging. They often say keep the patient awake, but the brain wants to sleep and rest. The reason for telling you in the ER to have your mother or your father or a wife or spouse keep you awake is that right after a brain injury, even a mild one, the bruise is accompanied by swelling. Now, if you hit your thumb with a hammer and it swells, you just get a big thumb and you put some ice on it and eventually it'll resolve. But if your brain swells, it's inside the skull and it doesn't have room to expand. So that swelling of the brain makes you sleepy and it can kill you because the brain, as it expands, eventually the compression basically strangles its own blood flow. And you need to, and staying awake doesn't help prevent the swelling. So it doesn't say anything other than if you're sleepy, you should go back to the ER and get another imaging study to make sure your brain swelling isn't getting worse. It doesn't mean that keeping you awake prevents the brain swelling or is actual treatment for the dire consequences. So the ER should tell the patient, in addition to keeping them awake, bring them back if they're sleepy, because we got to repeat the imaging to monitor the severity of brain swelling that might have occurred.
So what you're saying is that the brain, once it starts to swell, is kind of a captive of its own, own anatomy, because it doesn't have anywhere to really expand to, because it's trapped in the skull.
Correct. So keep, and the other things, of course, there are common symptoms, for example, blurred vision, ringing in the ears, and headaches. The good news about this is that those symptoms are generally not due to a brain injury, but rather the ears and the eyes and the skull or membranes outside the skull. Ringing in the ears, for example, or tinnitus, as well as even hearing loss, can be due to, and vertigo, can be due to, after the brain is shaken, the inner ear mechanism that controls balance is disrupted. And normally you have the ears balanced with each other through little crystals in pockets of fluid. And as those crystals float, they send signals to the brain stem about your head position. Gotcha. If the brain is shaken in a way that these otolith crystals, as they're called, are out of place, your head could be tilted like this, and you might think that you're actually standing up straight. And if you move your head or body slightly, things may spin or move in the wrong direction because your inner ear is no longer balanced. Luckily, that's not actual brain injury, and it either resolves on its own as the body fluids then replenish and rebalance the inner ear. Or there are treatments such as the EPLEY, the Epley maneuver. You can go to a neurologist or an ENT specialist, and they position your head in certain ways to basically shake the fluid and the otolith crystals back into place. So the blurred, yes, I'm sorry, go ahead.
No, thank you so much for actually differentiating the way a person can experience these symptoms. Some of these symptoms are experienced because of some of these ancillary areas, like the ears having a shifting in those crystals, like those otolith crystals that you talked about, and or a swelling in some of the blood vessels that are connected perhaps to the inside of the skull. And so that's one area where a person can experience symptoms. But then how about the brain itself being damaged as a result of trauma? That would be the second, and maybe is that a little bit more worrisome condition?
Well, yes, and let's stay with the symptom of vertigo and even tinnitus. Yes. Because it's important to have an examination and not just say, oh, it's only my inner ear. This is something for the doctor to decide, and a doctor such as an ENT or a neurologist trained in brain injury. If you have vertigo after a head injury, it could also be, as you said, an ancillary structure, but that can lead to brain damage. For example, you mentioned the chiropractor possible connection before. When you look at the anatomy of the brain, the blood vessels to the brain go through the neck, through intervertebral foramen, in the neck bones, the vertebrae. These are very fragile. The vertebral artery is going through the bones. Every time the neck bends, either way, either twisting or bending or flexing, extending, those blood vessels are being stretched and pulled. Now, in a young person, they're pretty bouncy, and it basically doesn't matter. I mean, if you shake your head too much, you might get some vertigo. People who are hypertensive may have a little bit of plaquing and stiffness or hardening of the blood vessels. And when they bend their head or look up and down, they get vertigo because those blood vessels are actually being compressed, and they have momentary ischemia to the brain stem that also controls balance and hearing and tinnitus. and may produce very similar symptoms, but clearly it's a lot more serious if the cause is loss of blood flow to the brainstem versus the otolith crystals in the inner ear being shaken out of place for a few weeks or days.
Do you think that a person having arthritic problems with those vertebrae can, I mean, being older and having arthritis in the neck area could also impact blood flow?
Yes, yes. People with arthritis or prior neck injuries that have developed some compromised spondylosis, for example, people who had neck surgery, spinal fusion, would also be more susceptible if they subsequently have head trauma.
So a lot of times, going back to the chiropractor example, patients will go and get their neck cracked, so to speak. So would that be recommended, especially after a head injury? Would that be a no-no?
The no-no situations would be, one, obviously, if they have not yet imaged the neck. Meaning a patient goes into the ER, says they've had a little bump on the head. The ER doctor thinks, oh, you know, it's okay. I've got 25 other patients that look sicker. Let's not bother with a CT scan or a neck cervical spine X-ray. And just instruct him to come back if he doesn't feel well, or see his primary doctor. And then the patient goes on and goes right to a chiropractor. That's a dangerous situation if that patient has not been cleared by imaging.
Excellent.
The other situation is if the symptoms could develop later. Maybe they are okay in the ER and they did have imaging that did not show any neck injury or bones dislocation or out of place. But then they have hypertension or diabetes and they go to a chiropractor, or have, you know, just they're driving and they're turning their head this way and they start getting vertigo. That could be that they have a plaque in one of the arteries. It could be the carotids in the front as well as the vertebrals. And due to the trauma they had a few days ago, that plaque has loosened and now it's throwing atherosclerotic emboli with mini strokes.
That's very serious.
Not necessarily mini. They could have a real stroke.
Yes.
And that's another dangerous situation.
Well, along those lines, do you think that the vertigo and the dizziness that comes with the vertigo, as well as headaches or tinnitus, these symptoms can be chronic after a head injury, and, you know, can they last maybe forever?
Well, yes. And of course, it has to do with the severity of head injury and also the cause of the symptoms. Generally, if it's for example, if we take vertigo, hearing, and the tinnitus, those symptoms tend to be self-limiting because they are extracerebral, if it's really due to the otoliths. If they persist, chances are that they're what we refer to as central, and they are caused by either circulatory or some type of brain injury that from that trauma or a subsequent event, such as a plaque causing a mini stroke.
From a layman's perspective, Dr. Young, is injury to a specific area, one specific area in the head, worse than an injury to another area? In other words, which parts of the brain are more vulnerable to injury than others, if there's such a thing?
Well, it's difficult to say. I mean, it's almost like saying, you know, you have 3 kids, which one do you love the most?
Yes.
Every part is important.
Yes.
You don't want to lose any of them.
Especially since it's a small part of the body, it's probably all vulnerable, is what you're saying.
That's right. I would say in terms of a life or death situation, a brainstem injury is, of course, the most serious. Because
that's the area that controls our vital functions.
Right, including breathing during sleep, including sleep itself, including the heart rate. There are people who develop cardiac arrhythmias after brain trauma or a stroke. even though they didn't have the arrhythmia before the stroke. And now we know this has to do with the connections between the right brain and the brainstem, the right hemisphere of the brain and the brainstem. Or the vagus nerve that controls so much. If part of the brainstem is damaged, it could even have irregular heart rate, and that would later be proved deadly.
Because it's known that it is the vagus nerve that affects our parasympathetic nervous system, or it can probably slow our heart down. Is that what you're referring to?
Yes, damage to the vagus nerve could actually speed up the heart or slow it down if it's overstimulated or irritated. And
could go either way.
Yes, and damage to the brain stem can cause arrhythmias of various kinds, not necessarily just in the vagal nerve center in the brain stem, not just the vagus nucleus, but all the connections that go from the brain stem to the organs, the vital organs, the heart, the lungs, the GI tract. Basically, the brain stem controls all the internal organs, as well as vascular tone, meaning if I squeeze my finger and blood flows back into it and it turns from white to pink, that's because something in my brain stem stimulated blood flow to that little finger, and after receiving a message that it was squeezed and turned cold for a few seconds or turned white for a few seconds. It's that close of a control. That's very delicate.
Speaking of close controls, or maybe a spectrum of events, you've talked about mild brain injury, you've talked about moderate brain injury, and then severe brain injury. Where does a concussion fit in this whole spectrum, and where does traumatic brain injury enter that spectrum?
Oh, yes. Well, the definitions have changed over the years as our understanding of brain injury has evolved with research and experience and treatment. We generally use the term concussion when we think there was no brain injury. Concussion refers to symptoms that have no physical or physiologic correlate to any findings on examination, laboratory, or imaging testing that would indicate that actual brain injury occurred. In other words, if somebody comes in with headaches, dizziness, maybe blurred vision, and even some depression and anxiety after a head injury, but the examination shows that their mental status is basically intact except for some anxiety and concentration issues, that their cranial nerves are intact except maybe a positive vertigo test for the positional type from the ear mechanism rather than from the brain. And a physical exam can distinguish whether the vertigo is coming from the brain or it's just an extracranial or extracerebral ear problem. And if their balance testing shows that the problem is in the nerves of the feet rather than something in the cerebellum or brainstem causing balance problems.
I see.
Then all those things that prove within a physical examination that prove that there is no brain injury would then classify that patient as having had a concussion, not a traumatic brain injury, which still needs treatment and follow-up examination. But it becomes less worrisome as far as permanent sequelae and epilepsy and permanent mental status disability.
So my next question is probably for a future video, but so far you have touched on symptoms that might have to do with dizziness, they might have to do with difficulty hearing, they might even have to do with probably visual deficits. Could those happen with a concussion, visual problems?
Yes, actually that is probably for another video. The system of vision control is tied in with positional control. eye movements and stabilization of one's position in space, standing and doing balance activities. And the vision system includes everything from the eyeball all the way to the occipital lobes in the back of the brain. And at any point, these could be disrupted by a head injury. If it's in the eyeball, we would call it part of a concussion, but it could have vitreous. When the vitreous, which is the jelly inside the eyeballs, is shaken,
yes,
it can actually cause streaks. If you imagine a bowl of jello and you shake it up, sometimes you get bubbles, or sometimes the jello, if it's firm, actually shears.
Yes.
But we're only talking about shearing of the jelly inside the globe of the eyeball, not shearing in the brain.
Yes.
And the ophthalmologist would examine you and tell you how serious that is and if that's going to cause any permanent visual loss. Mm-hmm. Sometimes it causes problems like glare or reflections inside the eyeball, as normally the vitreous should be crystal clear.
Yes.
So that the light can go directly from the pupil to the back of the retina.
Yes.
But if the vitreous has been disrupted, then those light rays aren't radiating straight back, but they might be disrupted, and that causes some vision problems, which are not brain injury, but it could be serious if there's permanent scarring.
Yeah,
of course. Yes.
There's patients.
Well, I was going to say a retinal detachment can also occur.
Yes.
And it must be distinguished from a retinal detachment by an ophthalmologist looking very carefully and taking photographs.
Wow, those are some serious concerns. Yeah, because patients will complain about things which I understand are benign, such as floaters, or they'll also report things like flashes of light, and then they might even complain of visual loss, which might be temporary, where they're actually seeing, where they say that their field of vision is disrupted. Some people talk about as if they're looking at stuff through half a cup of water. And sometimes they complain of a bleed inside the eye. Could those all be as a result of a concussion?
Well, yes, it would still be considered concussion, but the ophthalmologist would definitely have a lot more pathology to work with. Okay. A floater can be in the vitreous. The flashes of light can be retinal detachment beginning to happen.
Okay.
And a careful slit lamp examination is required, an automated visual field examination, and sometimes they send the patient back to me to do what's called a visually evoked potential response. And that the visually evoked potential response tracks the signal from the point of time when the light enters the eye and the retina is activated, all the way to the back to the occipital lobe when it responds, meaning that person knows that they've seen something. Mm-hmm. If the ophthalmologist looks at the eye, if the ophthalmologist looks at the eyeball and everything seems normal, there's no retinal detachment, no vitreous floaters or foreign bodies, they'll frequently refer the patient back to me saying, this problem is retrochiasmal, meaning it's behind the eyeball. And then it becomes neurology rather than ophthalmology. The eyeball itself is ophthalmology, and if everything there is okay, then the ophthalmologist says, oh, this could be a brain injury or an optic nerve injury. And then it becomes my job to figure that out.
So this has got a lot of layers of information, Dr. Young, that you're sharing. What we're gathering from what you're talking about is we need to take even a concussion, which we might minimize and say, oh, I'm feeling completely fine. We should take that seriously. Is that what you're recommending?
Yes, that is my recommendation. Don't take anything lightly. Okay. Always follow up and pay attention to your own symptoms. Keep a diary of a day-by-day log of what your symptoms have been since the injury, so that the doctor can then track what might be evolving or resolving, hopefully.
Yes, hopefully, yes, hopefully. So a concussion, by definition, then it could lead to complications, but in comparison to a traumatic brain injury, is a self-limiting condition?
Well, generally, yes, it would be because a concussion involves extracerebral structures that repair itself. Whereas a contusion or a brain injury, it can compensate for itself, but it wouldn't actually repair itself.
Again, this next question is probably for another video, but just like the brain tends to repair itself in the event of a concussion, or the body can repair itself in the event of a concussion. When you say that a contusion or a direct injury to the brain is a little more serious, or can be a lot more serious, are you suggesting that there are parts of the brain that cannot repair themselves?
Yes, the parts of the brain that are more vulnerable, in addition to the brainstem, are the hippocampus of the medial or mesial temporal lobes. These cells are very specialized, and they're the main memory center or memory processing center of the brain. Luckily we have two, but they don't have exactly duplicative roles. The right hippocampus is generally for visual spatial memories, and the left for verbal. And so you could lose one and you lose, if you're an architect, everything. For example, yes. you yes. might lose your career if you had a right temporal lobe hippocampal injury.
Thank you so much, Dr. Young. Those we can discuss some of those issues for the future, but I think the message that we want to focus on today is that any type of an injury, a head injury, can either be a concussion or worse, but we should not take it lightly.
Well said. Well said. Thank you, Julius.
Yeah, not a problem.
And
but
so,
thank you so much for giving us so much information and knowledge. In the way you have explained it has been very easy to understand and not complicated.
And we'll certainly let our viewers send questions through our YouTube channel or through our website, and then and maybe suggestions for further questions or questions that have arisen from these from this session right here.
Yes, absolutely. I think we should encourage all our viewers to feel free to share their personal experiences or experiences that maybe their friends or family might have had, and they had questions about these, but maybe the doctor was not able to answer those, or they didn't feel confident enough to ask those questions. Please feel free to share your questions.
Okay, thank you, Julius.
Thank you.
We'll call it a day, and thank you to everyone out there. And we welcome your future questions, and please visit our website, wentworthnorton.org.
Okay, folks, that's wentworthnorton.org for everybody's reference. Thank you very much. Thank you, Dr. Young.
Thank you.